This is still continuing for Lecture 1, Chapter 4, Stretching for Improved Mobility. The definition and purpose. So, stretching interventions when restricted mobility adversely affects function, reduce the risk of injury or re-injury. Stretching is a general term used to describe any therapeutic maneuver designed to increase soft tissue extensibility with the intent of improving flexibility and range of motion by elongating or lengthening structures that have adaptively shortened and have become immobile. Flexibility. There's dynamic flexibility and passive flexibility, as well as hypomobility. So flexibility is the ability to rotate a single joint or a series of joints smoothly and easily through an unrestricted, pain-free range of motion. Muscle length, joint integrity, and pre-articular soft tissue extensibility all interact to determine flexibility. Flexibility is maximized when the muscle tendon units that cross a joint have adequate extensibility to deform and yield to a stretch force. So in addition, the arithrokinematics of the moving joint, which is the ability of the joint surfaces to roll and slide, and the ability of peri-articular connective tissues to deform also affect joint range of motion and flexibility. Dynamic flexibility, this is a form of flexibility that's also referred to as active mobility or active range of motion, is the extent to which an active muscle contraction can rotate a joint through its available range of motion. Dynamic flexibility depends on the ability of a muscle to contract through the range of motion and on the degree and quality of tissue extensibility. Passive flexibility, also referred to as passive mobility or passive range of motion, is the extent to which a joint can passively be rotated through its available range of motion and depends on the extensibility of soft tissues that cross and surround a joint. Passive flexibility is a prerequisite for, but does not ensure, dynamic flexibility. Hypomobility, if you will please review, it's obviously we have went over this in 101 and 150, is the decreased mobility or restricted motion at a single joint or series of joints, which might be because of several different pathological processes that would be contributing to the limitation of range of motion. So these factors are summarized in Table 4.1. Contracture. So a contracture is a restricted motion, can range from mild tightness to irreversible contractures. Contracture is defined as the adaptive shortening of the muscle tendon unit and other tissues that cross or surround a joint, resulting in significant resistance to passive or active stretch and limited range of motion. The limitations associated with contractures can significantly compromise functional abilities. So contractures are described as the side of the joint that has the tissue tightness. If the tightness is on the flexion side of the flexion extension joint axis, it is called a flexion contracture. For a patient that has a shortened elbow flexor who cannot fully extend the elbow, they are said to have an elbow flexion contracture. The patient with a tight hip adductor who cannot fully abduct the leg is said to have a hip adduction contracture. So contracture versus contraction. The terms contracture and contraction, the process of active tension developing in a muscle during shortening or lengthening. These are not synonymous and not to be used interchangeably. So types of contracture. So there are myostatic contracture. A myostatic contracture, although the musculotendinous unit has adaptively shortened and there's a significant loss of range of motion, there's no specific muscle pathology present. There is a reduction in the number of sarcomere units in series, and there is no decrease in individual sarcomere length, and myostatic contracture can be resolved in a relatively short time with stretching exercises. A pseudomyostatic contracture is impaired mobility and limited range of motion, result of hypertonicity, which could be spasticity or rigidity, associated with the central nervous system lesion, such as a CVA, a spinal cord injury, or traumatic brain injury. There is muscle spasm and guarding and pain with a pseudomyotic contracture. In both situations, the involved muscle appears to be in a constant state of contraction, giving rise to excessive resistance to passive stretch. If a neuromuscular inhibition procedure to reduce muscle tension temporarily is applied, a full passive elongation of the apparently shortened muscle is then possible. Arthrogenic and periarticular contracture is a result of interarticular pathology. These changes may include adhesions, synovial proliferation, joint effusion, irregulars in articular cartilage, or osteophyte formation. A periarticular contracture develops when connective tissues that cross or attach to a joint or the joint capsule lose mobility, restricting normal orthokinematic motion. A fibrotic contracture, or a irreversible contracture. So fibrous changes in the connective tissue of muscle and periarticular structures can cause adherence of these tissues and subsequent development of fibrotic contracture. Although it is possible to stretch a fibrotic contracture and eventually increase range of motion, it is often difficult to reestablish optimal tissue length. Permanent loss of soft tissue extensibility that cannot be reversed by non-surgical intervention may occur when normal muscle and organized connective tissue are replaced with a large amount of relatively non-extensible fibrotic adhesion, scar tissue, or hypertrophic bone. These changes can occur after long periods of immobilization with tissues in a shortened position or after tissue trauma and the subsequent inflammatory response. The longer a fibrotic contracture exists or the more extensive the tissue replacement, the more difficult it becomes to regain optimal mobility, and the more likely it is that the contracture will become irreversible. For an example, in the clinic, I have seen, especially for shoulder injuries or those that have were not compliant with the surgeon and they did not come to their therapy sessions after surgery for maybe a prolonged period of time, and they were having immobilization of the glenohumeral joint, they might have permanent damage to where you would not be able to achieve full range of motion even after having different periods of coming to rehabilitation. Another example would be I've known other patients to have to maybe they've had adhesive capsulitis and with therapy did not improve the changes, and they would have to go in and surgically improve the joint for increased mobility. Selective stretching is a process whereby the overall function of a patient may be improved by applying stretching techniques to some muscles and joints, while allowing motion limitations to develop in other muscles or joints. When determining which muscles to stretch and which to allow to become slightly shortened, you as a therapist must always keep in mind the functional needs of the patient and the importance of maintaining a balance between mobility and stability for maximum functional performance. The decision to allow restrictions to develop in selected muscle tendon units and joints typically is made in patients with permanent paralysis. So, for example, in a patient with a spinal cord injury, stability of the trunk is necessary for independence in sitting. With thoracic and cervical lesions, the patient does not have active control of the back extensors. If the hamstrings are routinely stretched to improve or maintain their extensibility, and moderate hypomobility is allowed to develop in the extensors of the low back, this enables the patient to lean into the slightly shortened structures and have some degree of trunk stability for long-term sitting. However, the patient must still have enough flexibility for independence in dressing and transfers. Too much limitation of motion in the low back can decrease function. Allowing slight hypomobility to develop in the long flexors of the fingers while maintaining mobility of the wrist extensors enables the patient with a spinal cord injury who lacks innervation of the intrinsic finger muscles to regain the ability to grasp by using a tenodesis action. Overstretching and hypermobility. Overstretching is a stretch well beyond the normal length of a muscle in range of motion of a joint and the surrounding soft tissues, resulting in hypermobility or excessive mobility. So creating selective hypermobility by overstretching may be necessary for certain healthy individuals, those that maybe participate in sports such as a baseball pitcher, that require extensive flexibility. Hypermobility can create detrimental joint instability if the static supporting structures and or the dynamic muscular control of the joint are unable to maintain the joint in a stable, functional position during activities. Instability of joint could cause pain and may predispose a person to musculoskeletal injury. So, for example, I've had some patients, typically younger, that had between their teens and their 20s, that might have hypermobility and causing increased pain. So, as we perform interventions to decrease pain and to improve with strengthening, a lot of times their pain will decrease. There are many therapeutic interventions that are designed to improve the mobility of soft tissues to increase range of motion and flexibility. Stretching and mobilization are general terms that describe any therapeutic maneuver that increases extensibility of restricted soft tissues. Some other types of interventions would be manual mechanical stretching, passive and assisted stretching, self-stretching, and neuromuscular facilitation and inhibition techniques can also be referred to as PNF patterns. So stretching, manual or mechanical, passive or assisted. So an in-range stretch force will elongate shortened muscle tendon units and or periarticular connective tissues when a restricted joint is rotated just beyond its available range of motion. The force can be applied by manual contact or mechanical device. It can be sustained or intermittent. When the patient is as relaxed as possible during the stretch, it is called passive stretching. If a patient assists in moving the joint through a greater range, it's called assisted stretching, or which is different from range of motion. Okay, so there's active range of motion, active assisted range of motion, and passive range of motion. But here we are referring to stretching. Self-stretching is as it sounds. They perform stretches that you would educate them through. Neuromuscular facilitation and inhibition techniques. So neuromuscular are founded on the concept of relatively decreased tension in shortened muscles prior to or during the stretch, because the use of inhibition or facilitation techniques to assist with muscle elongation is associated with approach to exercise known as PNF, proprioceptive neuromuscular facilitation. Many clinicians and authors refer to these as procedures as PNF stretching, active inhibition, active stretching, or facilitated stretching. Later on in the chapter, we will discuss more on the principles of PNF. Muscle energy techniques are manipulative procedures that are evolved out of osteopathic medicine designed to lengthen muscle and fascia and to mobilize joints. The procedures employ voluntary muscle contractions by the patient in a precisely controlled direction and intensity against a counterforce applied by the practitioner. As demonstrated last semester in PTA 150, I showed you a muscle energy technique for leg discrepancy. If you can refer back to that, and I believe that there were videos as well. Joint mobilization and manipulation, which we'll talk about in the next chapter. So I'm going to skip over that. Soft tissue mobilization we'll also talk about next chapter, but they are soft tissue manipulative techniques that are designed to improve the extensibility of any soft tissue that limits mobility. These techniques are specific and progressive manual forces, utilizing sustained manual pressure or slow deep stroking. Neural tissue mobilization are techniques used to improve or restore nerve tissue mobility. Nerve tissue mobility may become restricted by tissue adhesions or scar tissue following trauma or surgical procedures. Now we're moving on to indications, contraindications, and potential outcomes of stretching exercises. So indications and contraindications for stretching. There are situations in which stretching exercises are appropriate and safe. However, there are also instances when stretching should not be performed. If you look at box 4.1 and 4.2, they list the indications and contraindications for the use of stretching interventions, which we'll go over those in just a minute. For increased flexibility and range of motion, the expected outcome of stretching exercise is to restore and increase muscle tendon unit extensibility to regain or achieve the flexibility and range of motion required for functional activities. As discussed throughout the chapter, we will be talking about body of evidence shown as stretching, particular static and PNF stretching procedures, improve flexibility, and increasing range of motion. You will need to know the parameters of stretching exercises to determine effectiveness, such as intensity, duration, and frequency, that we will talk later on. And here's the list of indications for stretching. So if there's adhesions, contractures, or scar tissue, limited range of motion, potential for structural deformity, diagnosis, treatment, limited range of motion. If there's muscle weakness, shortening of muscles, part of a total fitness program, or pre and post vigorous exercise. Some common conditions related to the immobility would be prolonged immobilization, restricted mobility, connective tissue disease, neuromuscular disease, tissue pathology due to trauma, congenital and acquired bone deformities. So here's a clinical question. Why should the rectus femoris be stretched and prone instead of standing? For example, which position is best for stabilizing the pelvis? Well, prone helps stabilize the pelvis in neutral position or hip extension. Standing has tendency to flex the hip, which equals poor quality of a stretch. The patient can be in side lying, supine, or standing to stretch rectus femoris as long as their therapist assists patient in proper hip position. Here is the list of contraindications, which I'll talk more in depth, but this is on box 4.2 in your textbooks. But bony block, non-union fracture, acute inflammation or infection, sharp or acute pain with elongation, hematoma or tissue trauma, hypermobility. Hypermobility provides stability or control. Potential benefits and outcomes traditionally attributed to stretching exercises include the prevention or reduced risk of soft tissue injuries, reduced post-exercise or delayed onset muscle soreness, and enhanced physical performance. Injury prevention and reduced post-exercise muscle soreness. Although decreased flexibility has been associated with a greater risk of lower extremity musculotendinous injuries, it is not likely that stretching exercises prevent or reduce injury risk. Enhanced performance. Another potential benefit attributed to stretching is enhanced physical performance, such as increased muscular strength, power, or endurance, or improvements in physical functioning, such as walking, running, speed, and jumping abilities. Acute static stretching either has no effect or decreases rather than enhances muscle performance, which would be strength, power, or endurance, immediately following the stretching session. Acute stretching also provides no benefit or has a negative effect on the performance of activities that require strength, such as sprinting or jumping. These performance decrements are greatest when static stretches are held for longer than 90 seconds. To the contrary, acute dynamic stretching appears to lead to enhanced performance, especially with longer duration stretches, which would be more than 90 seconds. Dynamic stretching is defined as a controlled movement through the active range of motion for each joint. Performing stretching exercises as part of a comprehensive conditioning program on a regular basis over a period of weeks, which would be considered chronic stretching, not only increases flexibility, but also has beneficial effects on physical performance. This approach to stretching has been found to improve strength or power, perhaps because of an alteration in the length-tension relationship of the stretched muscles. Participating in a stretching program on a regular basis also has been shown to improve gait economy and enhance the performance of physical activities such as sprinting and jumping abilities. Properties of soft tissue and response immobilization and stretch. So when soft tissue is stretched, elastic, viscoelastic, or plastic changes occur. Both contractile and non-contractile tissues have elastic and plastic qualities, while only non-contractile connective tissues have viscoelastic properties. A stretched soft tissue is elastic if it returns to its pre-stretched resting length directly after a short duration stretch force is removed. Viscoelasticity, or viscoelastic deformation, is a time-dependent property of soft tissue that initially resists deformation, such as a change in length when a stretch force is applied, but will slowly lengthen if the force is sustained, and will gradually return to its pre-stretch configuration after the stretch force is removed. Plasticity, or plastic deformation, is the tendency of soft tissue to assume a new greater length after a stretch force is removed. Now we get into the mechanical properties of non-contractile soft tissue, which permits the entire body, and it's organized into various types of connective tissue to support the structures of the body, which include ligaments, tendons, joint capsules, fascia, non-contractile tissue, and muscles, and skin, which all possess connective tissue characteristics that can lead to the development of adhesions and contractures. Any of these tissues can lose extensibility and contribute to reduced mobility. When these tissues restrict joint range of motion and require stretching, it is important to understand how they respond to the intensity and duration of stretch forces, and to recognize that the only way to increase the extensibility of connective tissue is to model its basic architecture. Composition of connective tissue is composed of 3 types of fiber: collagen, elastin, retinaculin, and non-fibrous ground substance consisting of proteoglycans and glycoproteins. Collagen fibers are responsible for the strength and stiffness of tissue and resist tensile deformation. The stronger these bonds, the greater the mechanical stability of the tissue. Tissue with a larger proportion of collagen provides greater stability. Elastin fibers provide extensibility and have shown elongation with small loads and fall abruptly without deformation at higher loads. Tissues with higher amounts of elastin have greater flexibility. Reticulin fibers provide tissue with bulk, and ground substance is an organic gel containing water and its makeup of proteoglycans, which is also known as PGs, and glycoproteins. The PGs function to hydrate the matrix, stabilize the collagen network, and resist compressive forces, especially important in cartilage and intervertebral disc. The ground substance functions to reduce friction between fibers, transport nutrients and metabolites within the tissue, and maintain space between the fibers to help prevent excessive cross-linking between them. Collagen is the structural element that absorbs most of the tensile stress. With an externally applied load, collagen fibers elongate quickly as wavy fibers align and straighten. With increased loading, tension increases and the fibers stiffen. Continued loading will progressively increase fiber strain until a point where bonds between collagen fibers begin to break. When a substantial number of bonds are broken, the fibers themselves will ultimately fail. If failure of collagen due to tensile loading occurs at less than 10% increases in fiber length, whereas elastin may lengthen 150% without failure. However, collagen is 5 times as strong as elastin. In tendons, collagen fibers are parallel and can resist the greatest tensile load. Their fibers' alignment is in series with muscle fibers to transmit muscle forces to the bone. In skin, collagen fibers have a random orientation and so are limited in resisting higher levels of tension. In ligaments, joint capsules, and fascia, collagen fiber alignment varies so they can resist multidirectional forces. Ligaments that resist major joint stresses have a more parallel orientation of collagen fibers, and a larger cross-sectional area. The stress-strain curve. Here are the definitions for each of these. Overall, the stress-strain curve illustrates the mechanical strength of structures and is used to interpret what is happening to connective tissue under stress from an externally applied load. When a tensile load is applied to a structure, it produces elongation. The stress-strain curve illustrates the strength properties, stiffness, and amount of energy the material can store before failure of the structure. Stress refers to the amount of force being placed on the tissue. Strain is the change in length of the tissue compared to its original length. Elasticity is the ability of soft tissue to return to its resting length after a passive stretch. Plasticity is the tendency of soft tissue to assume a new length after the stretch is removed. There are also different types of stress. There's 3 different kinds of stress that develop into a structure response and applied load. So tension is a resistance to a force applied in a manner that will lengthen the tissue. A stretching force results in tension stress. Compression, resistance to a force applied in a manner that approximates tissue. Weight bearing through a joint will produce compression stresses. Shear is resistance to 2 or more forces that are applied in opposing directions. Which we will refer to back to this chart right here. The toe region is known as because the collagen fibers are wavy and within a 3-dimensional matrix at rest. Their first response to loading is to strengthen and align. This response occurs with minimally applied force and results in a small increase in tissue stress. The toe region of the stress-strain curve represents this behavior and is the range in which most functional activity normally occurs. The elastic range, or linear phase. So adjacent to the toe region, stress and strain have a direct relationship such that a change in stress results in a proportional change in strain. This is called the linear region, and its slope depends on the specific tissue's response to loading. A tissue that responds to loading with a rapid rise in strain, such as bone, will have a steep slope, higher stiffness than a tissue that responds with a smaller rise in strain. With respect to stretching, tissue stress beyond the toe region aligns collagen fibers in the direction of applied force. As strain increases, some microfailure between the collagen bonds begins and water may be displaced from the ground substance. If strain does not increase beyond the linear region or is not maintained, the tissue returns to its original size and shape when the load is released. The elastic limit is the end of the linear region and the point beyond which the tissue does not return to its original shape and size. The plastic range, which strain beyond this elastic limit begins to cause permanent tissue deformation. The plastic range extends from the elastic limit to the point of rupture, and tissue strained into this range will have permanent deformation after the external load is released. Plastic deformation results from sequential failure, also known as microfailure, of the bonds between collagen fibrils and eventually of collagen fibers. Because collagen is crystalline, individual fibers rupture rather than stretch, a process that may result in increased length from stretching. Ultimate strength. The maximum strain the tissue can sustain is its ultimate strength. Once this point is reached, further increase in strain does not result in increased stress due to tissue microfailure. The region of necking is reached in which there is considerable weakening of the tissue and it rapidly fails. Experimentally, maximum tensile deformation strain of isolated collagen fibers prior to failure is 7% to 8%, while whole ligaments may withstand strains of 20 to 40% before failing. Failure is reached when the tissue ruptures and loses its integrity. Structural stiffness. The slope of the linear portion of the curve, which would be the elastic range, is known as Young's modulus, or the modulus of elasticity, and represents the stiffness of the tissue. Tissues with greater stiffness have a steeper slope in the elastic region, with less elastic deformation as stress increases. Contractures in scar tissue have greater stiffness, probably because of greater degree of bonding between collagen fibers and their surrounding matrix. Tissues with less stiffness will demonstrate greater elongation than those with greater stiffness under similar external loads. The grades of ligament injuries, which is known as strains, are related to the stress-strain curve. So for grade 1 would be microfailure, rupture of some fibers after deformation into the early part of the plastic range. Grade 2 would be macrofailure, which is rupture of an increased number of fibers and partial failure after deformation into the later part of the plastic range. Grade 3 would be complete rupture or tissue failure after deformation beyond the plastic range. Time and rate influences on tissue deformation. Because connective tissue has viscoelastic properties, the amount of time and the rate at which an external load is applied to a tissue will affect its response. Rate dependence. When a load is rapidly applied to a viscoelastic tissue, the slope of the stress-strain curve will be steeper than if the load is applied slowly. The tissue becomes stiffer when the load is applied at a higher rate. This increased stress response protects the tissue by keeping deformation below the plastic range and minimizing the potential for failure. Viscoelasticity is an extremely valuable tissue property because it allows the body to tolerate high loads applied over short durations. A combination of encountered during high velocity events or activities. A tissue load that is applied gradually during a stretch will minimize this rate-dependent response. Again, here are the stress-strain curve, just as review. Elastic range, tissue taken to an end of range and gentle stretch applied. Collagen fibers line up. The elastic limit is the point beyond tissue returning to original shape and size. Plastic range is the permanent deformation fibers begin rupturing. Neckening, which means weakening, point right after before rupture. And failure, which is tissue rupture. Now we will move on to what's known as creep, which is the deformation of musculotendinous tissue. It's time dependent until it reaches when a gradually increasing external load is applied to viscoelastic tissue and is sustained, the tissue will continue to slowly elongate during the maintained stretch. The slow adaptation to sustained loading is a time-dependent property of viscoelastic tissue. The amount of tissue deformation depends on the amount of force and the rate at which the force is applied. Low magnitude loads reaching the elastic range and applied for long periods of time increase connective tissue deformation and allows gradual rearrangement of collagen fiber bonds, which would be known as remodeling, and then redistribution of water to surrounding tissues. Increasing the temperature of the tissue enhances creep and the extensibility of the tissue. Complete recovery from creep may occur over time, but not as rapidly as recovery from a short duration load. Long duration stretches applied to chronic contractures take advantage of this tissue property. For stress relaxation, when a subcellular load is applied to viscoelastic tissue and kept constant, there is gradual decrease in the force required to maintain the amount of deformation. This response is also a function of the viscoelastic qualities of the connective tissue and redistribution of water content. Stress relaxation is the underlying principle used in prolonged stretching procedures, in which the stretch position is maintained for several hours or days. Recovery versus permanent changes in length is dependent on both the amount of deformation and the length of time the deformation is maintained. For cyclic loading and connective tissue fatigue, repetitive loading of tissue within a short time duration increases heat production and may cause failure or at strain levels lower than what is needed for a single load. Examples of connective tissue fatigue from cyclic loading are stress fractures and overuse syndromes. According to animal studies, they confirmed that cyclic loading will result in decreased ligament stiffness, indicative of tissue damage sooner than will static loading. So for immobilization, it's increased collagen turnover resulting in weak tissue, causes collagen turnover and weak bonding between the new non-stress fibers, resulting in decreased stiffness. There is also greater cross-linking between disorganized collagen fibers and decreased effectiveness of the ground substance in maintaining space and lubrication between the fibers, resulting in adhesion formation. The rate of return to normal tensile strength for immobilization tissue is slow. Effects of inactivity, which is decrease of normal activity. So inactivity decreases the size and amount of collagen fibers, resulting in weakening of the tissue. There is proportional increase in the predominance of elastin fibers, resulting in increased tissue compliance. Recovery from these changes takes about 5 months of regular cyclic loading. Physical activity has a beneficial effect on the strength of connective tissue. With aging and its effects, there will be decreased tensile strength of tissue, decreased rate of tissue, adaptation, which is more prevalence of overuse injuries, tears, and ruptures. Aging decreases maximum tensile strength and stiffness of tissue, and the rate of adaptation to loading is slower. There is an increased tendency for overuse syndromes, fatigue failures, and tears of stretching. Corticosteroids has a long-lasting effect on the mechanical properties of collagen with a subsequent decrease in tensile strength. Adverse effects from corticosteroid injections include decreased collagen synthesis and organization, necrosis, and an increased ratio of type 3 to type 1 collagen. There is fibrocyte death next to the injection site with delay in reappearance up to 15 weeks. Mechanical properties or physiological properties of muscle tissue, I would like for you to review, as well as the contractile elements of muscle. We reviewed this during PTA 150, so all of this should be review. Didn't want to add too, though, that there are a number of changes in the anatomical structure and physiological function of the sarcomeres that can occur over time. These changes can result from a stretch during an exercise or from extended periods of immobilization followed by remobilization. The non-contractile structures in and around muscle can also affect a muscle's response to stretch and immobilization. Response to stretch. So when a muscle is stretched and is elongated, the stretch force is transmitted to the muscle fibers through the endomysium and the perimysium. During a passive stretch, both longitudinal and lateral force transduction occurs in muscle. So during the initial lengthening, tension rises sharply in the series elastic component. With continued lengthening, there is mechanical disruption of the cross bridges as the myofilaments slide apart, leading abrupt lengthening of the sarcomeres, which is sometimes also referred to as sarcomere give. When the stretch force is released, the individual sarcomeres return to their resting length. Response to immobilization and remobilization. There are morphological changes with muscle atrophy and weakness. As the immobilized muscle atrophies, an increase in fibrous and fatty tissue and muscle also occurs. The composition of muscle affects its response to immobilization, with atrophy occurring more quickly and more extensibility in tonic slow twitch postural muscle fibers than in phasic fast twitch fibers. The duration and position of immobilization also affects the extent of atrophy and weakness, with longer duration leading to greater atrophy and loss of functional strength. Atrophy can begin within as little as a few days to a week. Accompanying the decrease in cross-sectional size of muscle fibers with atrophy, and even more significant deterioration in motor unit recruitment occurs as reflected by an EMG activity. With immobilization in a shortened position, a decrease in the overall muscle length and the number of sarcomere results in muscle atrophy and weakness. It has also been suggested that a muscle immobilized in a shortened position atrophies and weakens at a faster rate than a muscle immobilized in a lengthened state. With muscle shortening due to immobilization, there is a shift in the length and the tension curve, decreasing its capacity to produce maximum tension as it contracts at its normal resting length. The decrease in muscle length also results in an earlier onset of passive tension as the muscle is stretched. This mechanical alteration is related to the new muscle length and to the increased proportion of connective tissue and muscle tissue that results from immobilization. With muscle shortening due to immobilization, there is a shift to the left in its length tension curve, decreasing its capacity to produce maximum tension as it contracts as its normal resting length. The decrease in muscle length also results in an earlier onset of passive tension as the muscle is stretched. This mechanical alteration is related to the new muscle length and to the increased proportion of connective tissue to muscle tissue that results from immobilization. The increase in connective tissue and early onset of passive tension also serves to protect the shorter and weaker muscle when it is elongated. Immobilization in a lengthened position. So sometimes a muscle is immobilized in a lengthened position for a prolonged period of time, usually during surgical procedures or such as limb lengthening. This application of series positional casts, serial casts, and the use of a dynamic orthosis to stretch a long-standing contracture and increase range of motion. There is some evidence from animal studies, but it's very limited in human skeletal muscle, that suggests that muscle held in a lengthened position for an extended time adapts by increasing the number of sarcomeres in series, sometimes referred to as myofibrillogenesis. Adaptation of the contractile units of muscle, or an increase or decrease in number of sarcomeres, to prolonged positioning in either lengthened or shortened positions is transient, lasting only 3 to 5 weeks if the muscle assumes its pre-mobilization use and degree of lengthening for functional activities. Which gives the purpose to for home exercise programs and patient education for the need to continue activities of daily living or exercises with full range to maintain effectiveness. Neurophysiological properties of skeletal muscle. The properties of the muscle tendon unit will also influence a muscle's response to stretch and the effectiveness of stretching interventions. In particular, two sensory organs of muscle tendon units, known as the muscle spindle and the Golgi tendon organ, GTO, are mechanical receptors that convey information to the central nervous system about the physical environment within the muscle tendon unit. This transformation often results in muscle responses that may impact the effectiveness of a stretch. A muscle spindle is the major sensory organ of muscle and is sensitive to quick and sustained tonic stretch. The main function of muscle spindles is to detect and convey information about muscle length changes and the velocity of those changes. Muscle spindles are small, encapsulated receptors composed of afferent sensory fiber endings, efferent motor fiber endings, and specialized muscle fibers called intrafusal fibers. Intrafusal muscle fibers are bundled together and lie between the parallel to the extrafusal muscle fibers that make up the main body of a skeletal muscle. Intrafusal muscle fibers connect at their ends to extrafusal muscle fibers, so when a muscle is stretched, intrafusal fibers are also stretched. Intrafusal muscle fibers can also contract, but only their ends, polar regions, not their central portion, are contractile. When an intrafusal muscle fiber is simulated and contracted, it lengthens the central portion and activates the sensory receptors in the nuclear bag and chain. Small diameter motor neurons, known as gamma motor neurons, innervate the contractile polar regions of intrafusal muscle fibers and adjust the sensitivity of muscle spindles to detect length changes. Large diameter alpha motor neurons innervate extrafusal fibers. There are two general types of intrafusal muscle fibers, the nuclear bag of fibers and nuclear chain fibers, named based upon the arrangement of their nuclei in the equatorial region. Primary type 1A efferent endings, which arise from nuclear bag fibers, sense and cause muscle to respond to both quick and sustained stretch. However, secondary, which would be type 2 efferents from the nuclear chain fibers, are sensitive only to sustained stretch. The primary and secondary afferent snaps on alpha or gamma motor neurons, which when stimulated cause excitement of their own extrafusal or intrafusal muscle fibers, respectively. There are essentially two ways to stimulate these sensory efferents by means of stretch. One is by overall lengthening of the muscle, and the other is by contraction of the intrafusal muscle fibers via the gamma efferent neuropathways. The GTO is a sensory organ located near the musculotendinous junction of extrafusal muscle fibers. The function of a GTO is to monitor changes in tension of muscle tendon units. These encapsulated nerve endings are woven among collagen strands of a tendon and transmit sensory information via the fibers. These sensory organs are sensitive to even slight changes of tension on a muscle tendon unit brought on by passive stretch or active muscle contraction during normal movement. When muscle tension develops, GTO activation signals to the spinal cord inhibit alpha motor neuron activity and decrease tension in the muscle tendon unit. With respect to the neuromuscular system, inhibition is a state decreased neuronal activity and altered synaptic potential, which diminishes the capacity of a muscle to contract. Originally, the GTO was thought to respond only to high levels of muscle tension as a protective mechanism for muscle. However, the GTO has since been shown to have a low threshold for firing.
functioning to continuously monitor and adjust the force of active muscle contraction during movement or the tension of muscle during passive stretch. Neurophysiological response of muscle to stretch. So the stretch reflex is a quick or sustained stretch force applied to a muscle tendon unit. The primary and secondary afferents of intrafusal muscle fibers sense these length changes. These afferents signal synapse with alpha motor neurons in the spinal cord to activate extrafusal muscle fibers. This motor response is known as the stretch reflex, defined as an increase or facilitation of active tension in the muscle being stretched. This increased tension resists lengthening and is thought to compromise the effectiveness of the stretching procedure. When the stretch reflex is activated in a muscle being lengthened, decreased activity, which would be inhibition, in the muscles on the opposite side of the joint also may occur. This is referred to as reciprocal inhibition, but to date has only been documented in studies using animal models. To minimize activation of the stretch reflex and subsequent increase in muscle tension, a slowly applied, low-intensity prolonged stretch is considered preferable to a quickly applied, short-duration stretch. Autogenic inhibition is in contrast. The GTO has an inhibitory effect on the level of muscle tension in the muscle tendon unit in which it lies, particularly if the stretch force is prolonged. This effect is called autogenic inhibition. Inhibition of the contractile components of muscle by the GTO is thought to contribute to reflexive muscle relaxation during a stretching maneuver, enabling a muscle to be elongated against a less muscle tension. If a low-intensity, low-stretch force is applied to a muscle, the stretch reflex is likely to be activated as the GTO fires and inhibits tension in the muscle, allowing the parallel elastic component, which would be the sarcomeres of the muscle, to remain relaxed and to lengthen. And this is just an overview of the definitions that we just mentioned. Now we're getting into properties affecting soft tissue elongation. For determining a type of stretching exercise, there are a number of essential elements that determine the effectiveness and outcomes of stretching interventions. The determinants, which would also be known as the parameters of stretching, all which are interrelated, include alignment and stabilization of the body and body segment during stretching, the intensity, duration, speed, frequency, and mode of stretch, and the integration of neuromuscular factors and functional activities into stretching programs. By manipulating the determinants of stretching interventions, which are defined in box 4.3, you as a therapist have many options from which to choose when designing stretching programs that are safe and effective and meet the needs, functional goals, and capabilities of many patients. Each of these determinants is discussed in this chapter. Alignment is positioning a limb or the body such that the stretch force is directed to the appropriate muscle group. Stabilization is fixation of a bony segment that has an attachment of the muscle to be stretched. Intensity of stretch is the magnitude of the stretch of force applied. Duration of stretch is the length of time the stretch force is applied during a stretch cycle. Speed of stretch is the rate of initial application of the stretch force. Frequency of stretch is the number of stretching sessions per day or per week. Mode of stretch is the form or manner in which the stretch force is applied, which would be static, ballistic, or cyclic. Degree of patient participation, which would be passive, assisted, or active, or the source of the stretch force, which would be manual, mechanical, or self. Therefore, many decisions, particularly those related to the type, intensity, duration, and frequency of stretching, must continue to be based on a balance of scientific evidence and sound clinical judgment by the therapist. There are 4 broad categories of stretching exercise, which would be static stretching, cyclic or intermittent stretching, ballistic stretching, and stretching techniques based on the principles of PNF. Each of these forms of stretching are effective in elongating tissue and increasing range of motion. Each can be accomplished in various ways, manually or mechanically, passively or actively, and by a therapist or independently by a patient, giving rise to many terms that are used in literature to describe stretching interventions. The stretching interventions are listed in box 4.4. which includes static, cyclic, ballistic, PNF, manual and mechanical stretching, self-stretching, passive stretching, and active stretching. Alignment and stabilization. Just as appropriate alignment and effective stabilization are fundamental components of muscle testing, goniometry, and all other therapeutic exercise, they are also essential elements of effective stretching. Alignment, which is proper alignment or positioning of the patient and the specific muscles and joints to be stretched, is necessary for patient comfort and stability during stretching. Alignment influences the baseline amount of tension present in soft tissue, affects the available joint range of motion. In addition to the alignment of the muscle and joint to be stretched, the alignment of the trunk and adjacent joints must also be considered. Stabilization. So to achieve an effective stretch of a specific muscle or muscle group and associated particular structures, it is imperative to stabilize or fixate either the proximal or distal attachment site of the muscle tendon unit being elongated. Without stabilization, the attachment sites are free to move with the tissue, reducing the ability to effectively maximize the organ insertion distance. Either site may be stabilized, but for manual stretching, it is common for a therapist to stabilize the proximal attachment and move the distal segment, as you can see in figure 4 of 10. Stabilization of multiple body segments also helps maintain the proper alignment necessary for an effective stretch. So for an example, when stretching the iliopsoas, the pelvis and lumbar spine must maintain a neutral position as the hip is extended to avoid stretch to the low back region. Sources of stabilization include manual contacts, straps or belts, body weight on a firm surface such as a table, wall, or floor. Intensity of a stretch. The intensity of a stretch is determined by the tensile load placed on soft tissue to elongate it. There is general agreement among clinicians and researchers that stretching should be applied at a low intensity by means of a low load. Low intensity stretching, in comparison to high intensity stretching, is more comfortable for the patient and minimizes voluntary or involuntary muscle guarding, enabling the patient to remain relaxed or assist with the stretching maneuver. Low-intensity stretching results in optimal rates of improvement in range of motion without exposing tissues, possibly weakened by immobilization, to excessive loads and potential injury. Low-intensity stretching has also been shown to elongate dense connective tissue, a significant component of chronic contractures, more effectively and with less soft tissue damage in post-exercise soreness than a high-intensity stretch. Duration of a stretch. One of the most important decisions you as a therapist will make when selecting and implementing a stretching intervention is the duration of stretch that is expected to be safe, effective, practical, and efficient for each situation. The duration of stretch refers to the period of time a stretch force is applied and tissues are held in a lengthened position. Duration most often refers to how long a single cycle of a stretch is applied. If more than one repetition of stretch, which would be a stretch cycle, is carried out during a treatment session, the cumulative time of all the stretch cycles reflects the total duration of stretch, which is also referred to as the total elongation time. In general, the shorter the duration of a single stretch cycle, the greater the number of repetitions needed during a stretching session. Many combinations of duration and cycle have been studied and determined optimal effectiveness. Static stretching is a commonly used method of stretching in which soft tissues are elongated just beyond the point of tissue resistance and then held in the lengthened position with sustained stretch force over a period of time. The duration of static stretch can be predetermined prior to stretching or be based on the patient's tolerance or response during the stretch. There's considerable variability in defining the duration of a static stretch. The term has been used to describe a single stretch cycle ranging from as short as 5 seconds to as long as 5 minutes per repetition when either a manual stretch or self-stretch is employed. If a mechanical device provides a static stretch, the time frame can range from almost an hour to several days or weeks. Static progressive stretching is a term characterizes how static stretching is applied for a maximum effectiveness. The shortened soft tissues are held in a comfortable lengthened position until a degree of relaxation is felt by the patient or therapist. Then the shortened tissues are incrementally lengthened even further and again held in the new end-range position for an additional duration of time. This approach involves periodically adjusting joint or segment alignment to increase the stretch force and capitalize on the stress relaxation properties of soft tissue. Most studies have been explored. The merits of static progressive stretching have examined the effectiveness of the dynamic orthosis, which allows the patient to continue the degree of joint angular displacement. Manual stretching and self-stretching are also routinely applied in this manner. Cyclic or intermittent stretching, a relatively short duration stretch force that is repeatedly but gradually applied, released, and then reapplied multiple times during a single treatment session, is described as a cyclic intermittent stretch. With cyclic stretching, the end-range stretch force is applied at a slow velocity in a controlled manner and in relatively low intensity. For these reasons, cyclic stretching is not synonymous with ballistic stretching, which is characterized by high-velocity movements. There is no clear differentiation between cyclic stretching and static stretching that is repeated several times during a treatment session. According to some authors in cyclic stretching, each cycle of stretch is held between 5 and 10 seconds. However, others refer to stretches 5 and 10 second duration as static. There is also no consensus on the minimal number of repetitions during a treatment session needed to differentiate cyclic and static stretching. In practice, determination is often based on the patient's response to stretching. Although it is limited, cyclic loading has been shown to increase flexibility as effectively or more effectively than static stretching. Speed of stretch. Importance of the slowly applied stretch. To minimize muscle activation during stretching and reduce the risk of injury to tissues and post-stretch muscle soreness, a stretch force should be applied and released at a slow rate. A slowly applied stretch is less likely to increase tensile stresses on connective tissues or to activate the stretch reflex. A slowly applied stretch also moderates the viscoelastic effects of connective tissue, making them more compliant. In addition, a stretch force applied at a low velocity is easier for the therapist or patient to control, making it safer than a high velocity stretch. Ballistic stretching is a rapid, forceful intermittent stretch, high velocity and high intensity stretch, characterized by fast joint movement that quickly elongates this targeted soft tissue. Dynamic stretching, noted earlier as a stretch shown to enhance performance, uses controlled movement to stretch muscle groups. Dynamic stretching is similar to ballistic stretching in that it moves the joint through its range of motion, yet differs by doing so at a low velocity and intensity. As dynamic stretching is emerging as a viable replacement of static stretching prior to athletic activities, may also have the potential to be appropriate for general fitness or rehabilitation programs. Although ballistic stretching safely increases range of motion in young, healthy subjects participating in conditioning programs, it is, for the most part, not recommended for elderly or sedentary individuals or patients with musculoskeletal pathology or chronic contractures. They would be based upon, the rationale for this recommendation is based upon tissue weakened by immobilization or disuse or easily injured. Dense connective tissue found in chronic contractures does not yield easily with high intensity, short duration stretch. Although controversial, there are situations in which high velocity stretching is appropriate for certain individuals. A highly trained athlete involved in a sport such as gymnastics requires significant dynamic flexibility and may need to incorporate high velocity stretching in a conditioning program. Also, a young active patient in the final phase of rehab who wishes to return to high demand recreational or sport activities after an injury may need to perform carefully progressed high velocity stretching activities prior to beginning plyometric training or simulated sport specific exercises or drills. When high velocity stretching is deemed appropriate, low intensity stretches are recommended while paying close attention to effective stabilization. The following stretching progression is designed to improve dynamic flexibility using a transition from static to dynamic stretching and then to ballistic stretching. First, you would perform static stretching, slow short end range stretching, slow full range stretching, fast short end range stretching, fast full range stretching. The strength force is initiated by having the individual actively contract the muscle group opposite the muscle and connective tissues to be stretched. Frequency of stretching refers to the number of individual sessions per day or per week that a patient carries out the planned intervention. The optimal frequency of stretching is based on factors such as the underlying cause of impaired mobility, the quality and level of tissue healing, and the chronicity or severity of a contracture, as well as the patient's age, corticosteroids, and previous response to stretching. The mode of stretch. Stretching exercises can be executed in a variety of ways. The mode of stretch refers to how the stretch force is applied and who is actively participating in the process. Categories include but are not limited to manual and mechanical stretching and self-stretching, as well as passive, assisted, or active stretching. Regardless of the mode of stretch selected and implemented, it is imperative that the shortened muscle remain relaxed and that the restricted connective tissues yield as easily as possible to the stretch. Stretching should be preceded by either low-intensity active exercise or therapeutic heat to warm the tissue that are then to be lengthened. There is no best form or type of stretching. What is important is that the therapist and patient have many modes of stretching from which to choose. As you can see in box 4.6, lists some questions the therapist needs to answer to determine which forms of stretching are most appropriate and likely to be effective for each patient at different stages of a rehab program. Manual stretching, which would be characteristics. During manual stretching, the clinician or caregiver applies an external force that lengthens the targeted tissue beyond the point of tissue resistance. The therapist manually controls the site of stabilization and the direction, rate of application, intensity, and duration of stretch. Manual stretching can be performed passively with assistance from the patient or even independently by the patient. Manual stretching typically employs a controlled static stretch applied at an intensity consistent with the patient's comfort level. It is held for 15 to 60 seconds and repeated for at least several repetitions. The intensity is often increased as tolerated for subsequent repetitions in an effort to achieve progressive lengthening. With manual stretching, it may be most appropriate in the early stages of a stretching program. When a therapist wants to determine how a patient responds to a varying of intensities and duration of stretch, and when optimal stabilization is most critical. Passive manual stretching by the therapist or caregiver is appropriate if a patient lacks neuromuscular control of the body segment to be stretched and cannot perform a self-stretch. When the patient has adequate neuromuscular control of the body segment to be stretched, it is often helpful to ask them to assist the therapist with the stretch. Particularly if the patient is apprehensive about moving or having difficulty relaxing. When the patient concentrically contracts the muscle opposite target muscle to assist the joint movement, the target muscle tends to relax reflexively and allow elongation. This is one of the several stretching procedures based on the PNF techniques. Using procedures and hand placements similar to those described for self-range of motion exercises, as you can see in Chapter 3, the patient can also independently lengthen target muscles and periocular tissues with manual stretching. This is described as self-stretching and will be described more on this topic in the next section. Self-stretching is also referred to as flexibility exercises or active stretching, is a type of stretching procedure done independently by the patient after careful instruction and supervised practice. Self-stretching enables the patient to maintain an increased extensibility gained as a result of direct intervention by a therapist. This form of stretching is often an integral component of a home exercise program and is necessary for long-term self-management of many musculoskeletal and neuromuscular disorders. Effectiveness. To facilitate effectiveness, the patient must be taught to perform self-stretching procedures correctly and safely. Factors identified earlier in the chapter, such as alignment, stabilization, intensity, dose, and mode, must all be addressed with the patient to prevent re-injury and maintain function. Application. The guidelines for the intensity, speed, duration, and frequency that apply to manual stretching are also appropriate for self-stretching. Static stretching for a 30 to 60 second duration per rep is considered the safest type of self-stretching. Self-stretching can be carried out in several ways. Using positions for self-range of motion exercises, as you can see and described in Chapter 3. If the distal segment of the shortened muscle is stabilized and the support surface, body weight can be used as the source of the stretch force to elongate the shortened muscle tendon unit. Neuromuscular inhibition using PNF stretching techniques can be integrated into self-stretching procedures to promote relaxation in the muscle that is being elongated. Low-intensity active stretching, referred to as dynamic stretching using repeated short-duration in-range active muscle contractions in the muscle opposite the target muscle, is another form of self-stretching exercise. Mechanical stretching involves a longer overall duration of stretches, practically with manual stretching or self-stretching exercises. Mechanical stretch duration reported in literature ranges from 15 to 30 minutes to as long as 8 to 10 hours per session, or continuous throughout the day except for time out of the device or hygiene and exercise. Serial casts are worn for days or weeks before being removed and then reapplied. The duration is dependent on the type of device, patient tolerance, and the cause, severity, and chronicity of impairment. Longer duration stretches are typically required for patients with chronic contractures stemming from neurological or musculoskeletal disorders rather than healthy subjects with mild hypomobility. PNF, which is the proprioceptive neuromuscular facilitation stretching techniques, which are referred to as active stretching or facilitative stretching, integrate active muscle contractions into stretching. These techniques are used to inhibit or facilitate muscle activation and to increase the likelihood that the muscle to be lengthened remains as relaxed as possible as it is stretched. The traditional explanation of the underlying mechanisms of PNF stretching is that reflexive muscle relaxation occurs during the stretch as a result of autogenic and reciprocal inhibition. This inhibition leads to decreased tension in muscle fibers and decreased resistance to elongation by the contractile elements of the target muscle. However, this come into question in recent years. Current thinking suggests that gains in range of motion during or following PNF stretching techniques cannot be attributed solely to autogenic or reciprocal inhibition, which involves the spinal processing of proprioceptive information. Rather, increased range of motion is the result of more complex mechanisms of sensorimotor processing, most likely combined with viscoelastic adaptation of the muscle tendon unit and increases in the patient's tolerance to stretching. Regardless of these competing explanations, numerous studies have demonstrated that the various PNF stretching techniques can increase flexibility and range of motion. However, the degree of neuromuscular relaxation associated with the PNF stretching maneuvers investigation was not determined in these studies. There is also some evidence that PNF stretching yields greater gains in range of motion than static stretching, but there is no consensus on whether one PNF technique is significantly superior to another. There are several different types of PNF stretching procedure, all to improve range of motion, which include hold relax or contract relax, agonist contraction, hold relax with agonist contraction. With classic PNF, these techniques are always performed with combined muscle groups acting in diagonal patterns. Over time, the techniques have been modified by clinicians and others to include stretching in a single plane or opposite the line of pull of a specific muscle group. For description of PNF and diagonal patterns, please refer to Chapter 6. Hold, relax, and contract, relax. With the HR and CR procedures, the range-limiting target muscle is first lengthened to the point of tissue resistance or to the extent that is comfortable for the patient. The patient then actively performs a pre-stretch in-range isometric contraction of the range-limiting target muscle against manual resistance applied by the clinician. This contraction is held for about 5 seconds and followed by voluntary relaxation of the target muscle. The limb is then passively moved by the clinician into the new range of the range-limiting muscle elongated. Clinicians with experience using PNF report that the HR and CR techniques appear to make passive elongation of muscles more comfortable for a patient than manual passive stretching. A sequence for using the HR and CR technique to stretch shorten pectoralis major muscles bilaterally and increase horizontal abduction of the shoulders. As we spoke earlier, the traditional explanation for PNF effectiveness is that neuromuscular relaxation results from autogenic inhibition following the pre-stretch isometric contraction of the target muscle. For agonist contraction, which is another PNF stretching technique, the agonist contraction, AC, can sometimes be misleading. The agonist in this case refers to the muscle opposite the range-limiting target muscle, while the antagonist refers to the range-limiting muscle. It may help to frame this paragraph as the short muscle, the antagonist, preventing the prime mover, the agonist, from actively achieving full movement. Dynamic range of motion and active stretching are other terms that have been used to describe the AC procedure. With the procedure, the patient concentrically contracts or shortens the muscle opposite the range-limiting muscle and then holds the in-range position for at least several seconds. The movement of the limb is controlled independently by the patient and is deliberate and slow, not ballistic. In most instances, the shortening contraction is performed without the addition of resistance. For example, if the hip flexors are the range-limiting target muscle group, the patient performs in-range prone leg lifts by contracting the hip extensors concentrically and holding at the end range of several seconds. After a brief resting period, the patient repeats the procedure. Increased muscle length and joint range of motion using the AC procedure have been reported. However, when the effectiveness of the AC technique has been compared with that of static stretching, the evidence is mixed. Precaution: avoid full-range ballistic movements when performing concentric contractions of the agonist muscle group. Hold relax with the agonist contraction. Combines HR and AC procedures. The HR and AC technique is also referred to as CRAC procedure, or the slow reversal hold relax technique, is where you move the limb to the point that tissue resistance is felt in the range-limiting target muscle. Then have the patient perform a resisted pre-stretch isometric contraction of the range-limiting muscle, followed by a voluntary relaxation of that muscle and an immediate concentric contraction of the muscle opposite the range-limiting muscle. So, for example, the stretch knee flexors. Extend the patient's knee to a comfortable in-range position, and then have the patient perform an isometric contraction of the knee flexors agonist resistance for about 5 seconds. Tell the patient to voluntarily relax and then actively extend the knee as far as possible, holding any newly gained range for several seconds. Recognize the same precautions as described for both the HR and AC procedures and follow the clinical tips to minimize complications and discomfort. The goals for stretching are to regain normal range of motion, mobility of soft tissues around joint, prevent irreversible contractures, increase flexibility, prevent injuries or decrease risk of injuries. Some other complementary exercises approaches that could be implemented would be relaxation training, Pilates, yoga, and Tai Chi, heat or cold massage, biofeedback, joint traction, or oscillation. You also want to take into effect some precautions. There are a number of general precautions that apply to all forms of stretching interventions. Some special precautions must be taken when advising patients about stretching exercises that are part of community-based fitness programs or commercially available exercise products marketed to the general public. Do not passively force a joint beyond its normal range of motion. Remember, normal, typical range of motion varies among individuals. In adults, flexibility is greater in women than in men. When treating older adults, be aware of age-related changes in flexibility. Use extra caution in patients with known or suspected osteoporosis due to disease, prolonged bed rest, age, or prolonged use of steroids. Protect newly united fractures. Remember that a longer lever arm creates greater torque on a joint. Always be aware that the point of force application on each of the segment will influence the tensile load on the target tissue. Avoid vigorous stretching of muscles and connective tissues that have been immobilized for an extended period of time. Connective tissues such as tendons, ligaments lose their tensile strength after prolonged immobilization. High-intensity, short-duration stretching procedures tend to cause more trauma and resulting weakness of soft tissues than low-intensity, long-duration stretch. Progress the dosage, which would be intensity, duration, and frequency, gradually to minimize soft tissue trauma and post-exercise muscle soreness. If a patient experiences joint pain or muscle soreness lasting more than 24 hours after stretching, it is likely that too much stretch force caused an inflammatory response. This in turn can result in increased scar tissue formation. Patients should experience no more residual discomfort than a transitory feeling of tenderness. Avoid stretching edematous tissue as it is more susceptible to injury than normal tissue, and continued irritation usually causes increased pain and edema. Avoid overstretching weak muscles, particularly those that support body structures in relation to gravity. Some contraindications to stretching would be a bony block, limiting range of motion, unhealed fractures, acute inflammatory process, sharp pain presenting with muscle elongation, hematoma or tissue trauma observed, contractures that add to a patient's functional ability. This is just a review of the PNF stretching techniques. Integration of functional into stretching, such as ADLs. The importance of stretching or strength and muscle endurance. Use of increased mobility of functional activities. And we will move on into lab about the different types of stretching for the upper extremity, lower extremity, neck and trunk, and self-stretching techniques.